Today, we are going to discuss about the risk factors for diabetes, starting from genetics to lifestyle. So, why risk factor assessment is critical? So, we need to understand diabetes is not an one-off disease. It is a continuum of metabolic failure, a progressive metabolic failure that evolves over many years. By the time of fasting glucose level crosses 126 mgdl, which is the threshold for diagnosing diabetes, by the time we recognize 50% of the beta cell function is already lost, microvascular injury has already begun, cardiovascular risk is already elevated. So that's why it is essential for us to assess the risk factors and make early interventions so that we will be able to prevent any diabetes developing in future, as well as preventing the complications relevant to the diabetes, including cardiovascular risk. So therefore, the purpose of risk factor assessment is to identify metabolic vulnerability, detect early pathophysiological changes, and intervene before irreversible beta cell loss is there. So diabetes as a continuum. So there are different clinical stages, which is for most of the normal glucose, normal people, the normal glucose tolerance, which is absolutely normal. There is a second stage, which is before pre-diabetes, which we need to understand, which is the compensated insulin resistance, which is where the insulin resistance has increased. So basically, body produces more insulin, but clinically, the patient is still normoglycemic. So the third is the pre-diabetes, which we all know, FBS between 100 and 126, whereas HbA1c between 5.6, 5.7, and 6.4. The other is over diabetes. We all know HbA1c above 6.4, 6.5, or FBS above 126, or RBS above 200 mgdl associated with any other symptom of diabetes. And then the last stage is the insulin diabetes. They become resistant to hypoglycemic drugs, oral hypoglycemic agents, and then they have to take insulin. So this is the five main stages of diabetes. Each stage has distinct laboratory features which we need to understand so that we will be able to treat the patient accordingly. So there are two biological axes that determine the risk of developing diabetes. All risk factors act through one or both. The first is insulin resistance, the second is beta cell reserve. Insulin resistance occurs in muscle, liver, as well as adipose tissue, whereas beta cell reserve is the ability of pancreas to compensate. So most of the time, pancreas tries to compensate the development of diabetes. Patients develop diabetes when insulin resistance exceeds beta cell capacity. So what does the clinical meaning of risk factors? So we need to understand risk factors are not equal. Some predict insulin resistance or dominance, which is the insulin resistant dominance phenotype, which is common in obese and sedentary. Others predict beta cell vulnerability. So there we need to understand there are two components. One is the insulin resistance, second is the beta cell vulnerability. There is a history of family history of beta cell vulnerability, or type 1 disease, or a LADA, lean Indians, or gestational diabetes mellitus, or latent onset diabetes in adults. So any of this, the other risk factors include the beta cell vulnerability, especially seen in with a history of family history of early onset diabetes, or lean Indians, or gestational diabetes mellitus, or LADA. So the correct interpretation tells us which tests to order, which diabetes phenotype to expect, which we are going to discuss in the next slides, and how aggressively we have to intervene so that we can prevent the patient from developing diabetes. So we need to understand how age increases the diabetes risk. With the increasing age, one is there is a decline in beta cell replication. So basically, there is a risk of insulin drop in the insulin production itself because there is a beta cell replication is declining. And then the second is mitochondrial dysfunction, increased oxidative stress, reduced insulin secretory response as well, leading to older adults tolerate metabolic stress very poorly and progress to diabetes quickly. So there is another side of it, which is the young onset of diabetes, which indicates there is aggressive biology. These guys needs to be treated very carefully. Young patients with dysglycemia often have strong genetic predisposition, early beta cell vulnerability, higher lifetime complication burden. So compared to regular people who develop diabetes because of obesity or poor lifestyle habits or sedentary lifestyle habits, the in the younger patients with dysglycemia have higher lifetime complications. So young dysglycemia should never be dismissed. So lean people with dysglycemia have to be attended promptly and then managed properly, and then they have to be counseled as well. So there is other South Asian and India or Indian diabetes phenotype. The characteristic features include high visceral fat at a lower BMI, so lower skeletal muscle mass, higher hepatic fat, early insulin resistance, along with limited beta cell reserve, resulting in diabetes development at a lower BMI as well as younger age. So, what is the clinical consequence of it? A lean Indian with hyperglycemia is not a mild diabetes, likely has significant beta cell dysfunction. Such patients progress rapidly and they might need insulin very early. What family history truly represents? Family history reflects polygenic inheritance, shared dietary habits, shared activity patterns, and epigenetic programming, indicating the risk of developing diabetes. So basically, if a patient has stronger family history, so there is a lower threshold for the diabetes. So, what are the laboratory clues that we get for genetic beta cell weakness? So, as we have discussed, there is uh, one is insulin sensitivity, second is the beta cell weakness. In genetically susceptible individuals, there is an early loss of first phase insulin response along with lower fasting C-peptide for given glucose with a rapid rise in postprandial glucose. So these changes occur before fasting glucose rises. So it is important for us or to test for other tests, which we are going to discuss in the next slides. So there is another risk factor, which is the visceral fat. Why visceral fat is more dangerous than BMI? Visceral fat releases free fatty acids directly into the portal circulation, increasing the hepatic gluconeogenesis, increasing the sugar levels, and at the same time, it produces inflammatory cytokines. This causes profound insulin resistance, leading to diabetes. So, always always record BMI along with weight circumference, especially if you are practicing in diabetes management. So please ensure, even for a general physician, it is always advisable to record BMI along with waist circumference, which will help us to ascertain the visceral fat. So 94 and above for men and 80 centimeters above for women, as per AHA guidelines, is a high risk of developing lifestyle related diseases and metabolic syndromes, including diabetes. Normal BMI with high waist is a high metabolic risk. So, along with BMI, this is also a very important clinical risk factor. So, muscle is the primary glucose disposal organ in the body. 70% of the post meal glucose uptake occurs in skeletal muscles. So, low muscle mass reduces the glucose sink, rises postprandial glucose, and increases the insulin demand as well. So, who has low muscle mass, they have again at a higher risk of developing diabetes. Especially, we see this in elderly, sedentary individuals, chronic illness, malnutrition. So, these patients develop diabetes even without obesity. So this we need to sensitize our patients so that they don't think, okay, I'm lean, I don't get diabetes. The another risk factor is the physical inactivity resulting in reduced glucose expression, glucose transporter type 4, which acts like a door to open when there is an insulin coming in. It opens the door for the insulin to get into the cell, which helps in controlling the sugar levels. At the same time, physical inactivity will also lead to increased insulin resistance, accumulation of visceral fat, clinically presenting as early postprandial hyperglycemia. So, what are the dietary patterns and beta cell stress? High glycemic load diets lead to repeated insulin spikes, leading to beta cell exhaustion, leading to early failure of beta cells and reduced insulin production. Quality of carbohydrates matter more than the quantity. So we need to ensure our patients, especially in pre-diabetic stage or those who have higher BMIs or high body visceral fat, waist circumference is on the higher side, we need to ensure they're taking proper diet, as well as their lifestyle is modified to include at least 150 minutes of exercise on a weekly basis and one or two strength training exercises in a week, so that muscle builds as well, which uptakes the glucose, as well as insulin sensitivity improves, leading to normoglycemic stage in future, or else they are at a very high risk of developing diabetes. So along with the quality of carbohydrate, the quantity is also more important. So when it comes to the pre-diabetes, which are all are been sensitized over the past few months, annual diabetes conversion is generally anywhere between 5 to 10%, indicates existing insulin resistance along with beta cell dysfunction, which is an earliest indicator for us to assess the patient is going to develop diabetes in future. So if the patient is having pre-diabetes, it is clear that there is an established metabolic disease. So he has already developed insulin resistance. His beta cell is already not functioning properly. So it is essential for them to go for aggressive lifestyle interventions so that they can come back to a normal glycemic stage, or else they are at high risk of developing diabetes, as well as it is confirms, though it is called as pre-diabetes, it is confirms the patient has an established metabolic disease. And then the second common is gestational diabetes. What does gestational diabetes indicate? Gestational diabetic indicates pregnancy stress unmasked limited beta cell reserve. So basically, there is a high risk of these people developing type 2 diabetes within next 10 years. Almost 40 to 60% of the people develop who has gestational diabetes during their pregnancy will develop diabetes in the next 10 years, as pregnancy has unmasked the limited beta cell reserve. Unless they take proper precautions, this might get repeated in the near future, leading the patient to develop diabetes in future. And then the other one is the PCOS. It is already indicates the patient is insulin resistant, a high lifetime diabetes risk. So we need to screen these patients very, very early. So what are the core screening steps to identify different stages? One is the normal glycemic or insulin resistance stage, or a pre-diabetes stage. First is, we all know, fasting plasma glucose. Second is HbA1c. Third is OGTT, oral glucose tolerance test. If we have any doubts about the patient, glucose tolerance has been impaired, especially after taking a meal. These detect dysglycemia, but not underlying biology. We need to interpret them in proper way so that we will be able to understand the underlying biology and then go with appropriate intervention based on the patient condition. So fasting insulin, first and foremost, is the fasting insulin, which is very, very important for early screening, reflects degree of insulin secretion. So high fasting insulin indicates the patient is already having insulin resistance. If the fasting insulin is normal, So then it indicates is a normoglycemic. If it is low, there could be a latent onset diabetes in adults or a type 1 diabetes. But high fasting insulin is an indicator of early insulin resistance, which is one step ahead of pre-diabetes. Low or a normal fasting insulin with hyperglycemia indicates beta cell failure. So fasting insulin should be ideally less than 10. 10 to 12 indicates early insulin resistance. More than 12 indicates pre-diabetes. So low or for normal fasting insulin with hyperglycemia indicates beta cell failure. The second most is the HOMA-IR, which is the insulin resistance index. The formula to calculate HOMA-IR is you have to it is fasting glucose into fasting insulin divided by 405. Value of 2 indicates insulin resistance. 3 indicates significant insulin resistance, useful in early disease, especially one step before pre-diabetes. One is to or look for fasting insulin. Second is to look for HOMA-IR. Third is to look for C-peptide. These will help us to ascertain the beta cell function as well as insulin resistance. The reflex reflex C-peptide and insulin are produced in equal stage 1:1. So this indicates reflex endogenous insulin production. So normal or high indicates there is a preserved beta cell in function. If it is low, meaning beta cell failure. If the C-peptide is low, then there is a beta cell failure. We need to interpret all this along with glucose levels. And then the fourth is the OGTT pattern recognition. So elevated 2-hour glucose with normal fasting indicates. So basically, during the fasting, the levels were normal, but after taking 75 grams glucose after 2 hours, they have above 140 indicates there is a muscle insulin resistance. So this also is an early indicator of insulin resistance. Both fasting as well as postprandial or PPBS2 or PPBS is elevated above 140 indicates there is a advanced disease. Only elevated fasting glucose indicates hepatic insulin resistance. So what is investigation summary of investigations pattern? If the patient is having normal glucose with a high insulin, what does it mean? Basically, there is our body is able to compensate, but there is insulin resistance. So basically, compensated insulin resistance, because what to keep the sugar levels at a normal level, the body is producing more insulin, which we can identify with fasting insulin tests. So, but still the body is in normal stage, but it is highly likely he will end up in pre-diabetes or a diabetes at a very early stage. So the second is pre-diabetes with high insulin. Pre-diabetic is always indicates there is almost already a metabolic failure. Along with there is a high insulin. Basically, this is a insulin resistant dominant phenotype. He is highly unlikely, if he is not aggressively intervened and changed lifestyle modification, he will develop diabetes. Pre-diabetes with low C-peptide levels indicates beta cell dominant. So basically, the beta cells in the pancreas are failing to produce enough insulin. So there is a high risk of developing diabetes here as well. But this is more of a beta cell dominant. So we need to look for latent onset diabetes as well as type 2. We need to rule out beta cell dominant diabetes types. Diabetes is it is already the patient is having diabetes and his low C-peptide levels indicates that the patient is in a very advanced beta cell failure. There are high chances there will be a complete beta cell failure, making the patient completely dependent on insulin. So coming back to the insulin resistance dominant phenotype, generally patients are obese. The high fasting insulin is generally on the higher side. The HOMA-IR is also on the higher side. The C-peptide is also on the higher side. So the best way to treat this patient, so basically what it indicates, the patient is obese, so will, and then also probably he is sedentary as well. So his insulin resistance has gone up. So basically body has producing more insulin. So the HOMA-IR indication is also, index is also high. The high C-peptide indicates the pancreas is doing well, but it is likely to fail if the patient continues like this. So proper lifestyle modification along with metformin, they'll respond fully. And then with the lifestyle modification plays a very, very important role in insulin resistance dominant phenotype. The second is a beta cell failure dominant phenotype. This is, they are lean. These guys, entire family members will get confused. Why I got diabetes? He says, I don't have any issues. I'm clean, I'm healthy. But if you carefully dig into the family history, you will be able to identify dominant phenotypes in the family. So if you look at the C-peptide levels, generally there will be low C-peptide levels. As we have discussed previously, these guys are very high risk. They'll progress rapidly. We might need to start insulin very early in these patients. So now we will discuss a few case studies. A 24-year-old male, BMI is 21. Okay, it looks absolutely fine. His HbA1c is 6.2%, indicates he's in a pre-diabetic stage. So the fasting insulin levels is low to normal. C-peptide levels is low to normal. What it indicates, there is a beta cell dysfunction is already there, leading to most likely we need to, so there is, if it is completely zero, then it indicates type 1 diabetes. Still the insulin levels are there, so it indicates latent onset diabetes in adults. So the second case is an obese middle-aged patient. If you look at the clinical values, is a 48-year-old male. BMI is 31. So there's a very high BMI. So he's at a very high risk of developing diabetes. HbA1c is 6.4. So he's already pre-diabetic. There is high fasting insulin, indicates his insulin resistance is very high. High HOMA-IR reconfirms that. So, but the normal C-peptide levels are normal. What is the best this thing in this case? Lifestyle modification. It is an insulin resistant dominant pre-diabetes as well, based on the values. So what is the best management approach for this case? We can start with early lifestyle. Based on the clinical condition, we can start low dose metformin as well. But or else we can, if he is a patient is motivated enough, he can aggressively go for lifestyle modification. There is a woman with a history of gestational diabetes mellitus. She is 32-year-old. BMI is normal 24. Gestation history of gestational diabetes 4 years ago, but the waist circumference is 88. For men it is 94, for women it is 80. So anything above 88 indicates there is a higher visceral fat. She is currently asymptomatic, so no known diabetes. So but she is a gestational diabetes is there, though her BMI is in the normal levels, so which indicates beta cells, there is a reserve is very low. She might develop diabetes in future because of prior GDM. Patient is already high risk. So we need to, what are the logical steps? We need to order fasting plasma glucose as well as HbA1c. The fasting blood sugar levels are 108. The HbA1c is 6%. Indicates she is in pre-diabetes. So metabolic failure has already been established. What are the next steps? So basically pre-diabetes is there, indicates there is insulin resistance. As she is having gestational diabetes, she has only a limited beta cell reserve, so she has a very high risk of developing diabetes. We need to, what are the tests that we need to order? We need to order the fasting insulin as well as C-peptide. So fasting insulin is 18. So basically it is an insulin resistant phenotype, C-peptide is normal. So pre-diabetes with insulin resistant dominant phenotype. So high likelihood of progression without intervention. So management, she has to go for intensive lifestyle intervention, consider metformin, and she need to be monitored on an yearly basis. So another clinical case, 35-year-old male, his BMI is 22, diagnosed with diabetes 8 months ago, on metformin as well as sulfonylurea, but still HbA1c is 9.2, indicates that he is not responding to oral hypoglycemic drugs. So what needs to be done in this case? How we have to go forward with this case? So, so he is lean, his poor response to oral agents, early failure indicates beta cell dysfunction. So we need to consider LADA, latent, we suspect beta cell failure, latent onset diabetes in adults. So what are the investigations? We need to order C-peptide and GAD antibodies, which is the confirmatory of latent onset diabetes in adults, LADA. So results are C-peptide is low, GAD antibodies are positive. So GAD antibodies are positive indicates it is an autoimmune form of it, which is attacking on the beta cell, leading to beta cell failure, leading to low insulin production, leading to onset of diabetes in early onset of diabetes in adults with a thin body, thin and lean body. LADA, autoimmune beta cell destruction. So what is the management? So there is assess insulin production is low. Sulfonylurea in fact causes more damage. It might cause hypoglycemia attacks as well. We need to stop sulfonylureas. Start insulin early, especially in these patients. A family as well as patient counseling is very, very important. So another case where there is a obese patient with normal glucose but high insulin. So 42-year-old female, BMI is 34. So waist is 104. So basically she is at a very high risk of developing diabetes. ABS is still normal. HbA1c is still normal. So everything is normal. Is she is a high risk patient or not? She is a high risk patient owing to strong obesity as well as central adiposity. So we need to evaluate, we need to order fasting insulin as well as HOMA-IR levels. So now if you look at the fasting insulin, insulin is 28, so which is very high. HOMA-IR is 6.2, so more than 3 it is. So she is a very high risk. At the same time as per the AHA health risk, health is at a risk if the weight size of a man is over 94 centimeters, about 37 inches, and woman over 80 centimeters, about 31.5 inches. So basically, she is at a very, very high risk of developing insulin. She has a severe insulin resistance. It should be less than 10, whereas it is almost 28. Severe insulin resistance with compensated beta cell function. So her beta cells are working extremely hard to keep her sugar levels are under control. They might fail in the future, leading her to develop diabetes. Pre-diabetes not yet present, but she might directly end up in diabetes if there is a failure of beta cells. So management implications, aggressive lifestyle intervention, weight loss programs, repeat glycemic testing every 6 months. So algorithm, how do we order tests in patients at risk of diabetes? Our aim is to prevent diabetes in these patients. One is identify high-risk patients. High risk. In India, generally we keep 18.5 to 25 as the BMI, but Indians, it is 23 is the cutoff. Second, waist circumference is high for women if it is more than 80 or 31.5 inches. For men, it is around 37 inches. If they are above 37 inches, we need to consider them as a high risk patient. If there is any family history, we need to consider them as a high risk patient. If there is any gestational diabetes mellitus or a PCOS, so they are also high risk patients. So any hypertension and dyslipidemia patients are also high risk patients. Any steroid or high antipsychotic use indicates there could be a drug induced diabetes as well. So those are also high risk patients. So how do we test these patients? First line test is a standard fasting plasma glucose and HbA1c. If they find if them are 126 and above or 6.5 and above, which indicates they're already diabetic. They are in a pre-diabetic stage. Metabolic disease has already been established, so we need to initiate lifestyle modifications at the earliest for these patients. And if they are normal, so still we need to go for, there is a chances of high risk phenotype, which is the insulin resistance. If they are already pre-diabetes or diabetes, obviously we will go for the as per the guidelines. Even still, if they are normal, we need to go for fasting insulin, C-peptide. You can consider OGTT if they are not willing for a C-peptide or a fasting insulin. If their fasting insulin is high, then there is a insulin resistance is already there. If the fasting insulin is low, the beta cell destruction is already there. So, a phenotype classification: high insulin with a normal or a high C-peptide, insulin resistant dominant. If the normal or a low insulin along with low C-peptide indicates a beta cell failure. Basically, your pancreas is not producing enough insulin because there is a beta cell failure. So your insulin levels and C-peptide levels are low. Your insulin level is high. Your pancreas is working really hard to keep your sugar levels under control, normal or high C-peptide, but it indicates the insulin resistance. It is essential for the person to develop muscle and ensure his lifestyle has been changed, his dietary habits has been changed, so that insulin will become normal, helping him to not to go into a pre-diabetes or to a diabetes stage. So what is the action for each of this? If the insulin resistant is dominant, lifestyle, you can consider starting metformin. If the beta cell is dominant, you can go with early insulin because beta cell is failing, so insulin production is rapidly coming down. We need to start insulin. If it is a mixed stage, we can go for a combination approach. So, key clinical take home messages: diabetes risk reflects biology, not just weight. Lean patients can have severe disease, we need to keep it in mind. And then early labs can identify disease mechanism. Mechanism based therapy improves the outcomes rather than starting a OHA or an insulin very early. Again, a quick recap. These are the clinical stages: normal glucose tolerance, compensated insulin resistance, pre-diabetes, over diabetes, insulin diabetes. Over diabetes and insulin diabetes are already I mean, of course, we are going to cover it in future classes, which forms the majority of our practice. Pre-diabetes, which we commonly see, but the patients neglect, but we have to remember the metabolic disease has already been established. His insulin resistance might already be there. We need to order fasting plasma, fasting C-peptide as fasting insulin, as well as HOMA-IR levels have to be calculated, and appropriately we need to sensitize them. Compensated insulin resistance is a one step before pre-diabetes. This is where it is helpful for us to identify any diabetes early and treat the patient uh, accordingly. So this is again, these are the high risk individuals, BMI above or equal to 23. Almost many of the people fall in this bracket. Waist circumference is high. There is a family history, or the patient has had a history of gestational diabetes mellitus, PCOS, or hypertension, or all hypertension patient has to be screened for diabetes. Uh, and then dyslipidemia patients as well. If there is a history of steroid or antipsychotic use, first we'll go with the simple fasting glucose with along with HbA1c. If still there is a high risk phenotype is suspected, or if the pre-diabetes or diabetes is suspected, we need to go for a fasting insulin, C-peptide, and consider OGTT as well. So high insulin with normal higher C-peptide indicates insulin resistant dominant, whereas normal with low insulin plus low C-peptide indicates beta cell failure dominant phenotype. based on the phenotype. If it is IR dominant, lifestyle is the main intervention. We can consider metformin. Beta cell dominant, we have to consider, we need to sensitize, we need to counsel the patient along with their family members. If it is a mixed phenotype, we need to go for a combination approach. So diabetes, we need to understand risk reflects the biology, not just weight. Lean patients can have severe disease, especially LADA or a type 1 disease. Early labs can identify, sometimes we can see a mix of LADA and somewhere between mix of LADA and a regular type 2 diabetes. Early labs can identify disease mechanism. Mechanism is based on the mechanism based therapy improves the outcomes.